Okay, great. Good afternoon, everyone, and thank you for taking time out of your quarantine to join us today. I'm Matt Dioria. I'm Director of the Medicaid Policy Center here at the New Jersey Healthcare Quality Institute. For those of you that don't know, the Quality Institute is a multi-stakeholder membership organization that convenes healthcare leaders in New Jersey around the common goal of improving the safety, quality, and affordability of healthcare for everyone. A public health crisis such as the one we're now facing with COVID-19 tests our strengths and highlights our weaknesses. At the Quality Institute, we continue to have important conversations about today's toughest healthcare issues remotely through webinars, quality briefings, and other valuable resources such as this session on the best practices for using telehealth. We will get through this together by communicating these best practices and learning from our collective experience. Today, we're honored to be partnered in putting on this presentation with AARP of New Jersey. A couple housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website, www.njhcqi.org later today. All phone lines will be muted for the duration of the program to limit background noise, and you may ask questions at the end of the presentation by typing into the chat box. The topic, as I said, for today's presentation is the telehealth visit best practices for caregivers and older adults. We hope that by the end of this webinar, you will learn how to strengthen the clinician-patient relationships and improve the continuity of care using telehealth, how telehealth is revolutionizing the delivery of primary care during COVID and what that means for the future, strategies to communicate with your primary care practice to optimize a telehealth visit. Please be advised, it is not the intent of this program or its speakers to provide clinical or legal advice. So to our presentation, we are honored to have Crystal McDonald and Dr. Mary Campanolo as our expert speakers joining me today. Crystal is the Associate State Director of Advocacy for AARP New Jersey, where she helps to plan and execute campaigns to support family caregivers, improve healthcare access and affordability, promote retirement security, and ensure access to affordable utilities. Crystal brings over 10 years of experience in community organizing, health policy, and coalition building. Prior to her role at AARP, she was my colleague here at the Quality Institute doing Medicaid policy work. We still miss you, Crystal. Faith in New Jersey and worked for Citizen Action as well, and she's a graduate of Richard Stockton College of New Jersey. Dr. Mary Campanolo is a family physician and geriatrician, medical director for virtual graduate medical education, and chair of the Department of Family Medicine at Virtual Memorial. Dr. Campanolo treats patients at Virtua Family Medicine in Mansfield and Virtua Health and Rehab Center in Mount Holly. She's lead physician at the Mansfield practice and a member of the Virtua Medical Group Physician Action Committee and Quality Committee. Mary is also a Quality Institute board member. I've personally known Mary for nearly 20 years. She's been a leader in advancing improvements in primary care and integrated health, and I'm delighted to be working with both of them again. And so without further ado, I'll turn the presentation over to Crystal and Mary. I guess Crystal first.
Great, thank you so much, Matt, and Tyler and Virginia and all of the team members over at the New Jersey Healthcare Quality Institute. You are all some of my favorite people and definitely the smartest people I know. So I'm really privileged today to be joining you and to talk with you all a little bit about telehealth. So I'm gonna pull up my slides for you. Bear with me a second. All right. So I'm going to take just a few minutes today to talk to you a little bit about why AARP is involved and supportive of expanding access to telehealth. Talk a little bit about New Jersey's kind of legislative status with telehealth and what has changed during this COVID-19 public health emergency, and then talk a little bit about where we hope to go from here. And then I'll hand it over to Mary, who I'm very excited to be hearing from. So what is telehealth and how can it help me? And, you know, there are a lot of different definitions, and we'll talk about that some more today, but really telehealth is the use of digital information and communication technologies such as computers and mobile devices to manage you or your loved one's health and well-being, especially over distances, which is really critical at this time. Telehealth can include clinical services as well as health-related services, things like patient education, provider consultation, remote care, home monitoring, for example. And so it's not necessarily a unique medical service, but an innovative way for health services to be delivered to patients outside of a face-to-face visit with a healthcare provider. And you might be asking, well, how does this help me? So some of you might have used it already, but for many patients on the call, can you think of the last time you went to visit the doctor? And think about how long that whole visit took you. For many people, it can be a multiple hour affair for what is sometimes a visit of just a few minutes. And so telehealth has the potential to save you a lot of time and hassle and make sure that you could also have access to providers and specialty providers that you might not have access to during, off hours or in cases where there might be provided shortages, such as in rural areas. So it provides a lot of benefits for individuals, really helps you keep out of the waiting rooms, especially during this public health crisis, keeps you from being potentially in a waiting room with others who might be sick, and also helps family caregivers. And supporting family caregivers is a huge part of the work that we do at AARP. And telehealth can really help caregivers to be looped into visits with their loved ones. So the patient and provider will have to consent, but for a caregiver who lives far away, who can't get off of work, this helps them to be able to virtually join the telehealth visit with their loved one and their provider. It offers another set of eyes and ears to listen to what the provider has to say. And I know that has helped me in a lot of ways, especially when I was recently pregnant. I never could listen to anything the doctor had to say and wanted to interpret it my own ways, especially when I found out I had gestational diabetes. I was like, oh, sure, I can eat this many carbs during the day, but I had my husband there as a secondary listener to say, hey, no, they said, cut it out. So this is really helpful for family caregivers. And it's something that's great because right now a lot of us have the technology already on hand to be able to do this. So if you've used FaceTime or Skype during this public health emergency, then you've already tried out some of the tools that we're going to talk about today. And I know in my own personal experience, we use FaceTime really to talk with my parents and their grandkids every Sunday. And so it's something that should be easy, practical to use, and really help us out to make sure that we can get the medical advice that we need during this time. And why is AARP involved? So we talked about this a bit, but we really believe that telehealth is a promising tool that can help people access healthcare in new ways and make it easier for family caregivers to care for their loved ones. Our engagement on this issue is to advance the needs and preferences of our consumers, and especially for our family caregivers within telehealth. More and more, we hear from our members, especially those 50 to 59, who are using their mobile devices and tablets to access information about their health. And really, this can help with multiple solutions for people who want to access home and community-based services in new ways and make it easier for family caregivers to really help support those who want to remain at home as they age. So AARP is really committed to playing a role in helping make sure that the voices of our 38 million members across the country and the nation's 40 million family caregivers across the country are heard on this issue. And so we see it as a way to encourage our lawmakers and the industry to consider the needs and preferences of consumers, especially our family caregivers, as we're addressing telehealth in our states. And it's an area we really plan to be more and more involved in, and especially now, given the COVID-19 crisis, we really hope that a lot of the changes that have helped to make telehealth more accessible really are continued after this public health crisis. So how has COVID-19 impacted the telehealth landscape? Well, first, we have to talk about what was the landscape before that? And so, you may not realize, but there are a lot of barriers that limit the use of telehealth. Things like where can you be when you receive telehealth? What kind of devices can be used? What state is your doctor in? And then depending on which insurance you have, whether it be Medicaid, Medicare, private insurance, state health plan, there are different sets of rules about how you can access telehealth. So the coverage you have can really change based on your insurance. And at AARP, we're working and we'd like to see these barriers eliminated so that anyone can access telehealth. And prior to COVID-19, New Jersey had started to move forward in allowing the use of telehealth, but it's been happening kind of slowly. So while some providers have been practicing telehealth prior to 2017, in 2017 is when New Jersey passed a law that really helped more providers to be able to engage in telehealth. And the law did things like give a new definition to telehealth so that everybody's working with the same terminology, and did things to make sure that there was at least some partial coverage parity and address things like licensure and reimbursement. So a lot of the background things that enable us to be able to use telehealth more practically and easily. And in 2019, Governor Murphy enacted a new law entering New Jersey into the multi-state nurse licensure compact, which allows nurses who don't reside in New Jersey to provide care to New Jerseyans. And this really broadened access to providers for New Jersey patients, which really helped make telehealth more accessible because you had a broader range of providers that could participate. Now, in response to the pandemic, many states, including New Jersey, have moved quickly to provide increased access to telehealth. So Governor Murphy has enacted S2289, which allowed out-of-state providers to provide telehealth in New Jersey for coronavirus issues only. That's still widening the availability of telehealth to folks who have those coronavirus issues. He also enacted S2283, which requires Medicaid and private health insurance providers to provide coverage for telemedicine services during the state of emergency. So for Medicaid and private health insurance plans in the state, the law provides telehealth coverage parity and eliminates cost sharing for telehealth services, so making it a bit easier for patients to access telehealth. There are also many changes that were made in New Jersey Family Care's program, our Medicaid program, to allow more accessibility to telehealth as well. And on the federal side, there were also many changes. So nationally, Congress and the administration were very quick to act. And through the first coronavirus relief package and subsequent orders through the Centers for Medicare and Medicaid Services, they've lifted the geographic restrictions for Medicare, allowing someone to utilize telehealth at home, no matter where you live. Under Medicare, they've brought in the list of services available for reimbursement and sweetened the reimbursement for providers. And so more types of your needs can be addressed through telehealth, and there's an incentive for providers to be able to provide that service to you. And then Medicare also will now cover telehealth checkups and follow-up visits. So you have more coverage for telehealth services. And for anybody who's interested in kind of learning more about that, you can visit the Center for Connected Health Policies website. That's cchpca.org. And so really, I think if you take away anything from this, it's that telehealth really is a tool for you to be able to use to access healthcare when you need it, where you need it. And especially during this public health emergency, it can allow you to continue to get the healthcare services that you need without putting yourself at risk by going in person to a provider's office if you don't need to be there in person. It's something that was a little slow to get moving, not just in New Jersey, but in many places across the country. But now, as a result of this public health emergency, with many of the rules being relaxed and people really trying this out to get the services that they need, AARP is hoping that we can continue to make some of these changes that were temporary, make them permanent, get them expanded more broadly, and really continue to work on lifting barriers that prevent access to care to telehealth. So we're very excited to hear more from Mary. And for any of you who are caregivers, just wanted to share a hotline if you're having any questions or concerns during this public health emergency or beyond, we have the hotline listed there below that you can call for assistance. It's 1-800-424-2494. And with that, I'm going to hand it back over to Matt and to welcome Mary to the call. I'm very excited to hear what you have to share with us.
Hi, everybody. I'm just waiting for Tyler to put up my slides. Thanks, Crystal, for a great introduction. So I'm Dr. Campagnolo. I'm a family doctor and do a lot of geriatric care throughout my career. I've been practicing in Burlington County, New Jersey for more than 30 years. Just want to give a caveat that I'm also not a tech person, so I can't really answer real strict technical questions, but wanted to be able to give you an oversight of just my experiences in the past couple of months through the COVID pandemic and how we began to do telemedicine in my practice. So we could go to the next slide. So this was just a brief illustration of the various components that we're speaking about. And on the left side, you'll see a person with a smart watch and a pulse oximeter, which would be checking their oxygen level. And then there's a smartphone and somebody's laptop or computer hard monitor, and then a clinician. And just to, wanted to show that telemedicine and telehealth are often used interchangeably in our current discussions, but there are some minor nuances to this. So in the next slide, we can talk a little bit about that. So as Crystal was saying before, telemedicine is the use of telecommunication information technologies to provide clinical health care at a distance. And it eliminates distance barriers and can improve access to medical services that would not always be available in distant rural communities. It's also been used in critical care as well as other emergency situations. And so there were distant precursors to telemedicine, but essentially really came into being throughout the 20th century with development of technologies. So this was a definition I took from Wikipedia. I think it basically covers a lot of what has been previous telemedicine, but currently it's really available everywhere and does not necessarily have to be just for rural communities. Also, mostly what we're speaking about today is the advent of telemedicine into ambulatory practices of various kinds throughout our country. So we could go to the next slide. Again, just to illustrate a little bit of the nuance here, that the World Health Organization had also tried to make a distinction about between telehealth and telemedicine, where telehealth uses computer-assisted telecommunications to support management, surveillance, access to medical knowledge, and where telemedicine really is used for diagnosis and treatment of patients. So telehealth, I guess, the way I could have helped to explain that a little bit more is the nuance would be, as I showed in that diagram in the first slide, the use of various devices that a patient might have in their home or wherever they're at to help to monitor their statistics, such as their blood pressure, their pulse rate, their oxygen level, and all of those things can feed into the technology that might be available in their clinician's practice or other areas such as their insurers management team and health systems in general. And so that would be a distinction, I think, between the actual diagnosis and treatment of patients as opposed to just collecting their data and being able to use that to support their management. Interesting facts I found in researching for this today was that the first real telemedicine probably occurred in 1905 when a cardiologist named Einthoven transmitted electronic transmissions of EKGs, or the readings of heart rhythms. Next, during the 1920s to 1940s, as people were traveling on ships internationally and in large liners, that radio consultations between caregivers on the ships and on land were made to help treat with patients who became ill during their travel. Then as we moved into the 1950s and x-rays were being used extensively, there started to be transmission of x-ray images and to assist with interpretation of them by various consultants. NASA helped to support telemedicine in its astronauts, where people on the ground would help to treat their astronauts in orbit if there were problems or questions that arose. And then also the federal agencies started to look at rural healthcare through telemedicine and using some of the NASA technology in the 1970s and 80s. So then things were fairly quiet, I think, until we began to start using computers in a bigger way after the 1980s and 90s. So next slide, please. I was going to briefly touch on the legislation. I think Crystal did a nice job in summing things up. But basically, again, through the 90s and into the 2000s, then people were starting to see that we had some application of telemedicine that could be possible. It probably took at least more than a decade to bring the legislation in New Jersey to fruition. And we could go to the next slide. So in July of 2017, this legislation was first made prevalent or passed. The standards were made for who could do telemedicine in New Jersey. There were coverage requirements for state health plans, as well as Medicaid and the commercial insurers that practiced in New Jersey. The understanding to clinicians at the time is that there was not parity for payments, and that the rate that was given for a visit on telemedicine, the maximum would be at the in-person visit rate, but there could be lower rates of payment. Again, I think from a clinician point of view, we were very concerned that people participating in telemedicine would not necessarily be New Jersey licensed clinicians, and that could detract from the stability and viability of various practices in New Jersey. There was also the advent of companies that developed telehealth platforms earlier than the rest of us in the mainstream practice, and I think there was concern that those companies would infringe on the ability to practice in our state. And so there was a part of the legislation that required those companies to register yearly with the Department of Health and submit encounter data and reports on an annual basis. So then fast forward to this year, and just about overnight, things changed. And so in March of 2020, and again, I think there was a number of different pieces of legislation, but this one that I'm citing here is A3860, which for the COVID-19 public health emergency, that the telemedicine was to be covered without copays, without a dictated site of service, and for parity, at least for Medicaid, with in-person visits. And it also relaxed the relationship provisions. In the previous legislation, there was requirement to have an established relationship with the patient before you could do visits with them under telemedicine. And so that was eliminated in this recent regulation. And also there was to be no prior authorizations for telehealth by insurance companies. And then there was also some inclusion of directives to the companies that provide for state employees and retirees, which to my knowledge are Horizon and Aetna Medicare Advantage, that there were some directives from the Department of Banking and Insurance to how telemedicine would be covered by those companies. So next slide, please. So telemedicine and all the pieces of it are fairly complicated in one sense, but also can be very simple. And a lot of what we do in telemedicine, we can translate to how we do our basic visits with patients in person. And so again, I on this slide, there's a few, on the right upper corner, there's a few of the various devices that could be linked to telemedicine and telehealth now and in the future, to help get more aspects of a person's physical condition included, which is really one of the lagging parts of telemedicine right now, but I'm sure in future will change so that more physical exam tools will be available. The other parts on the bottom here show how there can be health centers that help to monitor these devices and the patient's status, as well as caregivers that are engaged with patients, as Crystal was previously talking about, and that also we should be aware when there is a need for emergency care, and finally, the basic doctor-patient interaction. And so next slide, please. So from my perspective, again, telemedicine, I put together here who, what, when, where, and why. So right now, under our current circumstances, who is anyone who, without a condition that requires immediate emergency department evaluation, immediate hospital care, or surgery. In the new Medicare guidelines that came out regarding telemedicine, which also came in March, right before the New Jersey legislation was passed, that a new patient under Medicare must be seen by a video and cannot be done with a phone telemedicine visit, whereas established patients may be seen or treated as telemedicine visits with phone or video or combination of those. So there is a distinction in that regard for Medicare right now. The what is right now, again, non-emergent acute and chronic conditions. I think there's a large application of behavioral health to telemedicine, and some post-hospital follow-ups could be done in this manner as well. The when, mostly I think we've been recommending pre-planned appointments probably are best, but they also could be on a same-day basis. And where, as mentioned before, the location requirements have been relieved, and so I've had patients personally have a visit with me from their car. It could be at home, at work, it could be in a park, wherever you have access to internet and or phone communication. Why? I think right now, again, continuity of care is really important, and I think we have lost some of that in the past 2 months with lack of ability to be able to have patients come into some practices, and lack of comfort for those patients to be in a group environment in any way. And again, there's regulations in our state currently disallowing that. Transportation difficulties have always been a big problem in many practices in rural areas, in inner city areas, and for patients who are no longer able to drive, and just in general unable to take public transportation. So that's always been a barrier that we've seen for continuity of care for patients. Right now, again, the paramount reason for telemedicine is the pandemic reducing access to care. And so now this has opened up a whole new way for us to be able to interact and keep track of our patients in need. It also could be used for meeting a new clinician. If you don't have a primary care practice to attend, you could potentially interact with a new clinician and established with that practice. Again, it could be used for behavioral health counseling and also just if you need some medical advice. Again, not emergent. I don't really think this is a platform where we would expect people to call with emergencies rather than calling 911. Next. So just wanted to speak about the telemedicine communications right now that are allowed are by telephone, which again is a huge advance. In the past, we've done many encounters with patients on the phone, but they weren't considered official visits. And so this can make those phone encounters a bit more robust and again, help to support a practice of being able to survive in this environment. Internet options would include smartphones, tablets, laptops. The thing we found that has been a hitch for some people who weren't aware that they did not have a camera on their laptops or on their other devices. Some or regular computers also don't always have a camera. So that's something that's really important if we're going to have a video visit. The common video platforms that, again, Crystal mentioned, FaceTime has been used a fair amount by patients and clinicians. Zoom has been used extensively. Skype, Doximity is a physician social media platform which has developed a very nice video and phone program that can be used for telemedicine. And there's also Google Duo. The Medicare rules that came out in March, again, which opened this up very widely, allowed all of these platforms, including phone as well, understanding that they are not HIPAA secure, meaning they don't always cover complete privacy for the health data and interchange. But I think Medicare felt that the risks of the privacy concerns were less than the need for patients to interact and get health care during this time of lockdown in many states. So again, right now, until the health emergency is lifted, we're able to use multiple types of platforms, which has been extremely useful. What we have found in my own health system, I'm sure in many other health systems that have electronic records, certain ones have embedded video platforms in the system. So for example, right now we use a program called Epic for electronic record, which has something called MyChart, which is the patient portal. And then that has also been connected with Zoom. And so that has made that whole connection HIPAA secure and private. And so going forward, after the pandemic lifts, I would expect that these are the kinds of situations that are going to be necessary for Medicare and other insurance coverage. Next slide, please. So I put together here just some ideas about different ways that the workflow can be optimal for people to have telemedicine visits with their clinicians. So from the practice side, what we've found is that we need to, again, the pre-visit, a pre-planned appointment probably works the best, but it can be done on a shorter term basis as well. Just there's often more bugs in that process. So we usually encourage that we have an appointment pre-scheduled at least a day or two ahead, and that the staff at the practice connect with the patient, make sure that their platform is operational, the patient understands how to use it, and also do what we do in routine care is that we try to plan the visit beforehand and understand what issues the patient might have had since the last visit, what medications they're currently on, find out if there's need for refills of certain medications, and find out if there's any outstanding labs or images or consults that we need to include in the discussion with the patient when we have the visit. So we try to encourage that all that's done, again, whether there's an in-person visit or a telemedicine visit at this time. For advice for patients, which includes a lot in the audience, I think, today, what we have been recommending, again, is to understand about the various platforms available to do a telemedicine visit. So in our case, we encourage patients to try to sign up for the patient portal ahead of time so they would be able to use that most secure platform. But if they don't have that opportunity, to see if they have those other platforms available on their smartphone that they could download the app for that, such as for Google Duo or FaceTime, to be able to use that when they have the visit with the clinician. And the fallback is always that right now we can continue to use a telephone and have a visit and pre-plan that visit. The other encouragement I have for patients is to keep a list of your medications all the time, but also, especially for this visit, have that handy and updated with any changes that might have happened since the previous discussion with the clinician. Also to see what bottles needed refills, and just kind of make a list of your questions that you would have for your doctor or nurse practitioner or physician assistant. And have those ready for discussion at the visit. What I found very helpful, and again, I think Crystal touched on this a bit too, is that it's really important to have your own care partner, whether that be a spouse, a child, another caregiver who understands your health needs, to have them with you nearby so that they could also help if there's some information that's missing or tests that were needed to just be discussed. Also, I found that's really important for diabetics to try to have been doing their home glucose readings and to bring those readings to their telehealth visit. Right now, again, we don't always have all of the interconnected devices at every patient's home, and so encourage patients to do their vital signs ahead of time if they have a monitor, a blood pressure cuff, which will show their pulses and their blood pressures. And again, whatever they can do, weigh themselves that day or have a list of their weights over a period of time. And I've found also a lot of patients are very nervous about technology, and certainly a number of our clinicians were nervous about this process. And so we're all trying to learn how to do this and to do it well. And I think practice improves all of us. So over time, I think we'll all get better at it. But I think I've seen some patients get so nervous about it that they freeze and then they can't carry forward the visit. And that's happened rarely, but it is an issue, I think. So I just encourage people to try to, plan ahead a bit and just try to stay calm, and that we work it out. We've tried to give patients lots of extra time to accomplish this. The challenges I've seen for patients are if they don't have a smartphone, if they have a flip phone, that pretty much limits the video platform unless they have a tablet or a computer at home with a video camera. The other concern has been sometimes people's devices are so full with apps that they can't download a new app, and so they realize that all of a sudden when they're trying to have the visit, and so that delays us a good bit of time if they need to erase other things to put in one of these apps. Again, I think technical knowledge is a challenge for many of us, and just something I think will come with time. But that's something a lot of patients really have to learn about, how these things work and how useful they can be once we understand. Sometimes there's been an issue about either the strength of the internet in the area or variability, as well as audio connections. And again, I think it's been really useful when the patients can do their own vital signs ahead of time and give us their home glucose readings for diabetics, but many people don't have the access to them. And actually in our own system right now, we're sending the patients who are discharged from the hospital with COVID-19 home with these devices that they can use and report to us and as time goes on in their recovery. So I think some of this will become more available for people in the future, whether purchased individually, provided by a health system or insurer. But those will be devices that I think will help us a lot in this process. Next slide. So I think what we were going to try next was to try to do a simulation of of a interaction, and I believe we had Matt was going to
Yes.
be our model patient.
Yes. Thanks, Mary. So I have a senior parent just discharged from the hospital, sitting with them, and now I'm talking to you about this. We're doing the follow-up visit from the hospital. So I'm trying to get these devices. So how do I go about, they tell me I need to monitor my parent's oxygen and blood pressure. Where do I go to get the equipment? How do I get that? Do you prescribe it? How do we do that through telehealth? And
Okay, so Mr. Joria, then what I would encourage would be in our system, potentially you would have a care manager who would be able to assist you with getting those devices, or you may have already had that on the discharge from the hospital. But otherwise, you would usually get that through well, first, blood pressure monitors are very available in most large online companies and in stores such as Target or Costco, Walmart. Actually, companies like that also often carry some of these other devices online, such as pulse oximeters and certainly glucometers and that. So with the glucometers, you usually do need a prescription for strips and lancets. Also, again, another resource would be your insurer as well to help to make sure whether you have coverage for some of these things. Unfortunately, they're not universally covered. So how is your father today?
he's doing well, but he's got some swelling in his ankles. We think it's from the medication. Can you take a look at them over Skype here or Zoom,
Yeah,
or do we need
can
to
you
come
move
in?
yeah,
We'll
I think
simulate that.
yeah, well, could you move the camera to his legs, and
Okay.
then we could take a look at that. The other question I would have would be, did he get weighed today, and do you have any other weight from a previous day in the past week?
I've been writing it all down. How do I get that to you? Do you want to see like every day, and should I just
Yeah,
email you that?
yeah, you could email that or put it through the patient portal that we have. We'll explain to you how to do that after we conclude today. But that would be really useful to be able to see. I guess what I'd wonder is, has he gained more than 2 or 3 pounds in the past few days?
Yeah,
Do you
his
know that?
weight's been good. Yeah, his weight's been solid. Yep, he's
Oh,
doing
good.
well there.
Okay.
Yep.
Okay. All right.
So yeah,
And as far as his breathing, how is he doing?
he's doing well, although he needs to do a follow-up with the pulmonologist. So do you schedule that, or do we schedule that? How does that work?
Yeah, well, what we usually do is that my assistant, Roseanne, she'll get back to you once we hang up, and she'll set up the appointments he needs, as well as show you how to get the vital signs to us,
Oh, that's great.
and plan our next visit too.
Excellent. Good.
Okay.
Great.
Does he have any questions for me right now?
No, I think that's it right now. I think others have questions. I get a couple
Okay.
here, I guess, as the moderator, so we'll jump to that
Yeah.
portion.
Okay.
I hope
All
that
right.
was useful for those who are
Yeah.
listening.
It's
To
just a
know what,
brief vignette, but those that's one thing I just wanted to mention that Matt brought to the fore here was we usually again try to do the pre-visit planning, but then also we have the post-visit follow-up from one of our assistants, which I've found is very helpful too. They get to check back in, find out if there was again anything that was missed that we need to follow up on again. Make the next appointment and help with making consult arrangements, sending out the requisition slips for labs and x-rays. So that's been a very important part of the visit.
okay.
Yeah, now we could get to some questions.
Yep, thanks to both Crystal and Mary. Before we move to the chat box questions, I just had a couple real quick. How do you determine if a patient has needs beyond what the telehealth visit can provide? And how do you go about, I guess similar to the question I just asked, how do you go about recommending those next steps?
Well, I would go back to the previous encounter just for an example. So if I had heard that his weight was rising, that he was feeling short of breath, that his pulse oximetry was running lower than the previous, all of those might indicate a need to at least come in the office, or depending how severe, possibly to seek out emergency room care. So there certainly are times like that. And then there's just some limitations. I had one example of a patient last week where met her for the first time on a video visit, and as part of the visit there was a mention of joint pains, and we initially tried to treat it with some over-the-counter and then prescription medications, which did not help. And so eventually what had helped her previously had been a steroid injection in her shoulder, and so I actually had her come in a few days later for a visit where we injected the shoulder. So you know, there's again going to be limitations to this where we just can't beat the face-to-face and clinical exam part of this interaction.
And so my next and last question will be looking ahead as we consider post-COVID. Do you see any practices that you developed during this that you'll continue because they actually increased safety and access for your patients?
Yes, I think, as I mentioned before, we have so many patients who often have transportation difficulty and at the last minute can't make it to the visit that we had planned an appointment for. And so I think if we know there's certain patients that have high problems with their transportation, often we might choose to consider more telemedicine access for them. And that way would be able to increase their access as well as not have appointments go empty that could have been filled with people who could come in. And so I think we're going to see a lot of that. I think in general, I could envision us going to a model where a certain portion of our day is always telemedicine, and then, you know, we go back to also our routine visits that just have to be done. Routine physical exams right now can't be done with telemedicine.
A brave new world. Okay,
Yes.
I'll turn it over to Tyler for the chat questions. Tyler? Having trouble hearing you.
Great, thanks, Matt.
Great.
We've gotten a lot of great questions in already. So if folks still have questions, just a reminder, we're not opening phone lines. So if you would put them into the chat box or Q&A, we'll get as many answered as we can in the time we have left. So a couple of great questions that came in already. One, Mary, I think you started to address, which was being able to see a provider through telemedicine without an established relationship. So we had a question come in that was, can I get a second opinion? So if I don't like the advice that I was given by perhaps my primary care provider, can I use telemedicine to maybe find a new provider?
Sure. I think, again, with the new legislations, the requirement for having a prior relationship has been lifted. So this could be something where you could meet some new clinicians and make a decision if you wanted to, either a specialist or primary care, where if you would want to make a change or get a different opinion. I mean, it's the same as in real life too, is that, you know, nobody's required to take advice that we receive from anybody, and you can always get other opinions. You should if you feel uncomfortable about what you've been told.
Great, thank you. And we have another question that came in on are medical insurance companies waiving co-payments for telehealth visits during this crisis? And I'll do a quick plug, and it's in our slides that I'll bring up at the end. But at the Quality Institute, we did create a telemedicine guide for patients. So we'll send that out as a follow-up after the presentation for folks on each of the different types of insurance and what they're offering right now in terms of support for telemedicine. And I hope that resource will be helpful for everybody, and hopefully will answer this question. But yes, insurance companies are waiving lots of payments.
Could I just add one thing on that, Tyler? Is that, one thing that it's probably for all of our organizations to consider advocacy on is that we're not sure for all the insurance companies how long the waiving is going to last and how long the parity of payments are going to last. And so right now, I think many of them are extending past June. Initially, we're going to end in June. And so that would be something to keep your eye on in the future, I think. And we can't expect copays to go away forever, but you know, I think given the circumstances, we do need some extensions.
Definitely, that's a great point. Another really great question that came in that I'd never considered before, the tech platforms that you mentioned, do you know if any of them, and is this possible for if a person has a caregiver that's not on site with them, can you also include them in the video visit? So for example, I know FaceTime, you can have multiple people on at once. I think Google Duo, obviously Zoom. Would you do that, have a person who is a caregiver, say a child from a different place join the call, if that's helpful?
I think that's entirely possible. I haven't done that yet, but it's like you said, all the platforms do have the opportunity for somebody else, as we're doing, can dial in from multiple locations. So that's again another advantage potentially of this whole situation, can help us with better communication with patients, caregivers, or power of attorneys.
Absolutely. And for, you mentioned a number of the things that patients can do at home, like taking their weight and perhaps their blood pressure, if they're able to get certain tools to be able to do that. Had a question come in about blood work. Is anyone doing, say, drive-through blood work services, or are there at-home services where someone can come and take blood work if that's needed, or does somebody need to come into the practice to do blood work?
So right now, the commercial labs, the major commercial labs are still doing blood work. They have been doing blood work throughout this whole pandemic. As well as our own practice has opportunities for blood work, and I'm sure many primary care offices do as well. The only home blood work I would know of that's kind of routine right now is what I already mentioned. I think the diabetic glucometers, as well as I didn't mention, which is has been also used for a long time now, is certain patients who are on blood thinner warfarin can monitor their anticoagulation INR testing at home, and usually there's a nurse shows them how to set it up, and then they can do it every week on their own. Those are two that are right now pretty available, but I'm sure again in the future there might be opportunities for expansion of that, but not right at the moment.
Great, thank you. And I know you mentioned this, but maybe you could elaborate on it. You mentioned that some of your staff in your office can do a pre-visit with a patient, especially if they're having trouble understanding the technology that they're going to be using for the visit, and perhaps they can walk them through that. Is there anything else that they might go over with the patient during a pre-visit to help them become more comfortable using technology?
So actually, one thing I didn't mention that we found as a larger organization that was important was we actually set up a patient hotline to be able to help if they don't understand or need more help than the staff at the office can immediately give. And so that's something we found as we instituted this over especially the past few weeks in a larger way with the Epic platform that we've instituted that. But as far as pre-visit planning, again, that's something we've been doing for all visits, in person and on telemedicine. And so usually, again, they want to hear about any hospitalizations or operations or consults that were done between visits, any lab work that was drawn, so we can go over, obtain those results if we don't have them, and go over that with the patient. And same thing with x-rays, and again, just any changes in medications and refills that might be needed, any special concerns that need to be brought up, helps to kind of make the visit more streamlined.
Great, that's wonderful. I mean, having a hotline, I think, is a big help for patients, especially if they need to try to do some of this work ahead of time, or if a caregiver is working to help them prepare. And I think we've gotten quite a few questions on specific questions or things that their providers may not offer right now. So I think, and you can certainly elaborate on this, but I think it's important to note that if your provider is not offering telemedicine services, or if they're not offering certain things that you're looking for, like having a caregiver on a call with you, now that the rules have been relaxed somewhat and you don't have to have an established relationship with a provider, I think a good piece of advice for all those asking would be to number one, ask your provider if they're providing certain services that you're looking for through telemedicine or telephonically if you don't have video capability, but also if they're willing to provide it, because I think a lot of providers, as you mentioned, Mary, are sort of learning and getting up to speed and offering more and more services to their patients as they get comfortable and as they get their practice up to speed. So certainly asking can't hurt. And if they're not happy with what they're being offered through that provider, perhaps looking for a new provider that does offer those services or hotlines or extra help if you need it. But happy to, have you elaborate on that, as we've gotten a lot of questions that we're not going to provide medical advice, certainly, but, in working with your provider, are there any other suggestions on how you could ask nicely if they're providing those services?
Yeah, so again, I would not want to be in a position, I certainly would not advocate anybody leave a primary care clinician that they've been seeing for many years. I think what you said is the right approach, that if somebody is not sure, they should call the office and ask. And especially now things are opening up a bit more, people who may have had to close a practice a short time probably would be starting to open. And so I would basically ask, and I think most of us, when you realize how easy actually the regulation or the lack of regulation on the government side right now, you can use any phone you have to do any platform you can manage with a patient. And so that's again how most of us who weren't doing this 2 months ago just started doing it, and we realized that it's not that bad, and we can manage to learn a lot about what's going on for the patients and help them out in this kind of uncertain time. So I would really ask a clinician to see what they can do, or if they want to try it. And my experience has been that just about everybody I know in New Jersey in medicine has been doing this if they're a front-facing type of specialty.
Absolutely. And we've done, I think, maybe 4 webinars so far on telemedicine in the last couple of weeks. And I've certainly seen all of our clinicians sort of rise to the challenge and are really learning and getting to know this type of caregiving. But yeah, certainly some of them may have been closed temporarily. So just giving a call and trying to see if they offer those kinds of services. And I think you also mentioned earlier, insurance companies are also offering telemedicine services. So if you can call your insurance company, they may offer something that you might like to partake in as well. And I think a question from a clinician who's in the audience as well. How do you determine the CPT code, decision-making complexity versus duration of time?
My understanding of this, and I hope it's correct, is that with the parity, basically if you do the same kind of documentation, what we call in medicine a SOAP note, and interact with the patient, understanding the limitations of physical exam, that we can bill at the same level we would have based on time or complexity of the visit with the patient. So that's basically what we've been doing. Again, I don't know how many of all the payers, how that has come back to us yet. We're still in the process of sending out billings March and April, and as far as I understand, that's been working out, though, according to as promised, that we would have parity on the types of visits.
Great, thank you. And one other question that I think you sort of alluded to in your patient visit with Matt, when somebody has a physical condition, you use telemedicine and video capabilities to look at if there's a rash or discoloration or things like that. Do you often do that with patients, where you'll look at their physical condition before trying to make them come in for an office visit?
Yeah, so far that's what I found has been really helpful. I've had people show me rashes, things in their eyes, different kinds of skin lesions, again, shoulder or pains and what's going on with their shoulder. Leg and feet problems, as Matt had shown about leg swelling, but also just foot deformity or something that's turned up on a toe. So there's a lot of things we actually can learn. And I've also found just actually looking at a person, you can assess their breathing, how at least they're breathing, if they look comfortable in their speech, if they're oriented to their speech and speaking clearly. So there's many things we really can learn. The problems are with actually hearing lungs or hearing a heart exam and touching an abdomen, those kinds of things we just can't do yet.
Great. And I think we've talked about this a lot with all of the telemedicine webinars that we've done so far. In some ways, telemedicine offers an even greater look at a person's health because you can get them at home where you can see their medications, be with their caregivers and their family members. So it's offering, I think, an even new dynamic to care that we haven't seen as prevalent before. And so we're just about out of time. So I'm going to just quickly share the telemedicine resource that I mentioned. We'll send this out to everybody, but it is a guide to telehealth in New Jersey. So just gives you a little bit more information about what's being offered and what's being covered right now. And Mary, as you mentioned, we may have to update this as they extend coverage for things, which I hope they will. And then lastly, we at the Quality Institute have done a number of different webinars and have offered a number of different resources on topics that we hope are valuable to folks, including webinars on telehealth, but also on the importance of physical therapy during COVID-19. Physical therapists are now using telehealth to treat their patients. So things like that, which have been really interesting. We've heard from a lot of different members. So I hope that folks will go to the link at the top there and check out all of the resources that we've put together. They're public and free for everybody to use. And we'll continue providing new resources as we approach our new normal, as Governor Murphy says. So just want to thank everybody for participating today, Matt for moderating, Crystal and AARP for being our partner here, and Dr. Campagnolo for being our wonderful board member and great presentation today. So we'll follow up with everybody after with an email with the recording and the slides, and hope everybody enjoyed the presentation.
Thank you.
Thanks.
Thank you so much.
Have a great day.
Bye, everyone.
Bye.